Femoral fractures, including the neck, intertrochanteric region, shaft, and distal segments, are often indications for surgical repair. The type of anesthetic technique may influence perioperative outcomes. Hip surgery under regional anesthesia was shown to have lower complications compared to cases performed under general anesthesia. Patient positioning to perform spinal anesthesia causes severe pain in patients with femoral fractures. Femoral fractures are particularly painful because the periosteum has the lowest pain threshold of the deep somatic structures. Effective regional analgesia techniques have been increasing in popularity because of the decrease in opioid requirement. Peripheral nerve blocks used for analgesia in hip surgery and femoral fractures include the following, which spare the obturator nerve. Because of this, the pericapsular nerve group or PEG block was developed by Giron Arango et al. It is an ultrasound-guided technique for blockade of the high articular branches to provide analgesia for the anterior hip. It was shown to significantly reduce pain scores compared with baseline in patients with hip fractures. The objective of this case series was to determine the efficacy of the PEG block in providing analgesia prior to positioning of patients with hip and femoral fractures for spinal anesthesia for surgery. 12 patients admitted in our institution for hip surgery were assessed by the investigators. Numerical Pain Rating Scale or NPRS scores were recorded prior to the procedure. After obtaining informed consent, the PEG block was performed 30 minutes before induction of spinal anesthesia. The PEG block was performed as described by Giron Arango et al. With the patient in the supine position under minimal sedation. Sonography was performed with a linear probe transducer in a transverse plane over the anterior inferior iliac spine and rotated counterclockwise to be aligned with the pubic ramus. This is a sonographic depiction of the needle's trajectory when performing a PEG block. The needle's target is the fascia plane deep to the psoas muscle and tendon between the anterior inferior iliac spine or AIIS and iliopectineal eminence or IPE. A single injection of 20 ml 0.25% levobupivacaine was injected in increments of 5 ml after checking for negative aspiration and adequate spread of the anesthetic. The needle here is inserted lateral to medial using an in-plane approach to reach the fascia between the IPE and AIIS. Notice the acetabulum a few millimeters below the IPE. It's the curved line. Local anesthetic is then injected. Take note of the psoas muscle lift as anesthetic is injected. 30 minutes 30 minutes after regional block placement, NPRS scores were recorded during positioning to the lateral decubitus position. A median or paramedian approach was used. After local anesthetic skin infiltration, dural puncture was done at the L3, L4, or L4, L5 interspace using a 25-gauge Quincke spinal needle. After visualizing free flow of cerebrospinal fluid, 3 ml of 0.5% heavy bupivacaine was injected intrathecally. After testing for adequate level of blockade, dexmedetomidine IV infusion was started for intraoperative sedation. Changes in blood pressure were managed either with fluids or vasopressors. Signs of local anesthetic toxicity were watched out for and noted. Patients involved in the study were aged 38 to 87 years with ASA classification of 2 to 3. Most fractures were intracapsular involving the femoral neck, followed by intertrochanteric. NPRS scores 30 minutes after the PEG block during positioning for spinal anesthesia were significantly reduced. 66% of patients had 0 NPRS scores upon positioning. All patients were positioned comfortably in the lateral decubitus with no evident signs of pain. No signs of local anesthetic toxicity were noted. Majority of fractures in the elderly involve the proximal third of the femur, with the neck being the weakest part of the bone. Spinal anesthesia is most commonly used for surgery of the femur, which may involve internal fixation of the fracture or replacement of the femoral head. Regional block techniques that have been proven to provide significant analgesia for pain during positioning for neuraxial anesthesia include the femoral nerve block and fascia iliaca block. Peripheral nerve blocks have several advantages for pain treatment for patients with hip fractures, including the following. MRI has demonstrated that the FIB and 3-in-1 blocks both did not penetrate the tissue plane between the iliacus muscles and psoas muscles, which was necessary to reach the obturator nerve. An anatomic study showed that the anterior hip capsule is innervated by branches of these three nerves, the FN, ON, and AON. Said articular branches in proximity to the inferomedial acetabulum and the space between the AIIS and IBE are targeted by the pen block. This block only affects the sensory branches of the hip joint, allowing a motor sparing effect. This could allow for easier positioning of the patient as compared to the FIB, which relaxes the quadriceps muscles. This picture from Tran et al. Demonstrates spread of methylene blue dye as injectate upon administration of the PENG block on a lightly preserved cadaver. The 3D model on the right shows that 10 ml and 20 ml of injectate were adequately spread in the pericapsular area, covering the three nerves that richly innervate the anterior hip capsule. NPRS scores were evaluated during positioning 30 minutes after administration of the PENG block because nerve block techniques performed using bupivacaine have a median onset time of 30 minutes for a complete sensory and motor block. According to Urbanek et al., L-bupivacaine has similar onset time. In this study, the PENG block using 20 ml 0.25% L-bupivacaine was found to produce significantly lower NPRS scores after 30 minutes compared to baseline, making it useful for providing analgesia prior to positioning. This was in accordance to the study by Hiron Arango et al., with median reduction of 7 points. Results also showed a larger difference in reduction in pain scores compared to other regional block techniques as reported by Guai, wherein pain scores decreased by approximately 3.4 out of 10. In conclusion, this case series was able to show that the PENG block is effective in providing analgesia to patients with femoral fractures prior to positioning for spinal anesthesia. A larger sample size, however, is needed to compare the efficacy of the PENG block to other techniques such as the femoral nerve, FIB, and 3-in-1 blocks. Thank you.
I'd like to congratulate you also for having that skill and expertise to perform PENG block on your patients. But maybe I would, you have only 12 patients, is it not?
Yes.
12, you did it only on 12 patients. Is that enough? Your population is not enough for your PENG block research?
For a comparative study, I don't think it would be enough. This was only discovered last year, this kind of block. So
No,
they're only limited.
You know, I made the research on that, and there was a report, the same kind of block, in the year 2009. And the one I reported is, of course, from the developed countries like the United States, wherein he collected a number of series wherein PENG block was done, and then he made an analysis on that, on those papers. What is the, did you request an approval of the committee on the ethics board, or you did not request at all?
Not for this study.
Why? Is it not that if you make a research, you have to have an approval? There must be a legal reason behind that.
For this case series, when we inquired with our IRB committee, they said that it would be okay to push through with this study without requesting for their permission.
What about the patient's consent?
We were
Did you have
able.
the approval of your patients?
Yes, we have written consent.
Did you orient the family? Because most of these patients are geriatric patients.
Yes po, we did.
Because
We were
you
able
have to consider also the complications that will involve the performance of your block. So, I don't think that you should eliminate also the approval of the ethics committee.
Thank you.
Just like what I said from the previous presenter, even if you're just doing a case series, you have to make sure that the process involved, you will be